And it gives me great pleasure to chair this session and introduce our next speaker, who is Rosie Gibson, long-term friend and collaborator, who is a associate professor at the University of Massey University now with the Heart Group. And she's going to talk to us about factors associated with sleep.
Thank you, Mari. Kia ora koutou, Rosie Gibson toku ingoa. As Mari said, I'm based at Massey University. I'm affiliated with the Sleep Wake Research Centre down here in Wellington, but more recently now in the School of Psychology with the Health and Ageing Research team. And so, yeah, today I'm going to be talking about sleep. So my background is in sleep research and sleep practice, as well as aged care. And so I'll cover off some of the work we've been doing around this topic using the interRAI data. So as I said, have affiliation with the Health and Ageing Research Team and Sleep Wake. And a lot of the work I'll talk about today was funded by the Health Research Council and the Emerging Researcher Grant, as well as some of the work we've done in Ageing Well. And I'm based between two campuses up on the Kapiti Coast, just an hour or so up the coast from here. So sleep's really important. We spend, in theory, about a third of our lives asleep. So by the time we reach that kind of retirement age, in theory, we spend over 20 years sleeping. And so we know that it plays a really important role for our physical and mental health, for growth, for rejuvenation, for our mood and overall well-being. But also in adulthood, about a quarter of people report sleep problems. And we know that there's physiological changes with aging and lots of unique sleep disorders of aging, but still it's kind of an overlooked issue when we're trying to better understand supporting older adults. And so a lot of my research work has been looking at data that we've collected through the health work and retirement cohort, as well as some of the LILACs data where we're looking at factors associated with sleep. But it's been really exciting to sort of move into working with interRAI into those really big data sets as well. A lot of my previous research has considered sleep and aging in the community setting for people with dementia and their care partners. And so I found it really interesting to understand people's experiences with sleep changing with aging, what unpaid carers were dealing with their own sleep, as well as the person they were supporting. Whoops, this is going to go on ahead by itself. And anecdotally, a lot of people sort of talk about how they feel that sleep changes when they move into residential aged care, and that potentially sleep's quite an issue in that situation. So we'll come back to that through the presentation. I guess just taking a step back, looking at the home care situation, sleep's represented in the interRAI, both the home care and the long-term care assessment in these following ways. So there's a measure for having difficulty sleeping. So that includes problems getting to sleep, staying asleep, restless sleep. So kind of what we associate with symptoms of insomnia. And then there's these measures of excessive sleep during the daytime, that it's kind of interrupting with daily functioning, as well as moderate to severe fatigue. And you can see in this initial assessment I did as part of my HRC project, we looked at about 6 years worth of data, and you can see that almost a third of people who, care recipients were defined as having difficulty sleeping, and almost half moderate to severe fatigue. And what I was interested in at this time was that relationship with carer burden or distress. And so about 40% of unpaid carers, or informal carers, if you like, involved with the interRAI were reporting having some degree of carer distress. And that was affiliated with earlier admission to residential aged care. And so this paper on the bottom there, we're exploring sleep's relationship to that carer distress. And we found that when the care recipient had sleep disturbances, carers were sort of 30% more likely to have report that feeling of distress. And similar still with the fatigue as well. If the care recipient was very fatigued, carers were about 30% more likely to report that distress. And that really resonates with the other paper you can see on here, where we did a survey in New Zealand for dementia-related carers. And we found there that if the caregiver's sleep was disturbed, as well as the care recipient, we noticed some really unique changes to sleep with dementia. When sleep of both parties affected, carers reported being more likely to be considering aged care transitions in the very near future, compared to those who sleep was not a problem. So that was really interesting to me. And I think, like I said, we found in the interviews with carers that they quite often talked about how, sleep was a big factor for them, for making some decisions in the family for transitions to care, and that from their experience that sleep kind of got worse with movement into long-term care. And so we heard Jo talk a little bit about this earlier, but we were really interested in what happens when people do transition into care. So we accessed the long-term care assessments for about 40,000 people who'd had both care assessments. So their last home care assessment and then their first long-term care assessment post-admission, so about six months, a year later. And this was affiliated with the awesome study that NARI led, which was the Aging Well study. And we were really interested in the factors around mobility, nutrition, oral health, and sleep, which was my sort of area, and then social connection. So those were our key indicators of aging well. And this is currently under review, but similar to what Jo presented this morning, we see actually that a lot of the factors that we think of as indicating poor health actually reduce with moving into aged residential care. So we see reduced odds of lots of these things like balance problems, falls, loneliness, and so on, but also with the sleep variables. People, once they move into residential aged care, they're about 15 to 20% less likely to report having problems with sleep or too much sleep, or and even we got 2.5 times more likely, less likely to be reported as having fatigue. So all of those indicators of problem sleep were actually higher when they were at home rather than residential aged care. And so that was an interesting finding for us. And as Jo presented this morning, she ran a stratified sample of about 1,500 of the MADI participants in that data set. And I think that speaks to perhaps, or come back to that idea around how we define sleep problems, perhaps. It looks like there's a change, and I think that does offer some solace to families considering residential aged care, that there are some of these key areas that do appear to improve with that change of context, but perhaps the way we think about sleep and talk about sleep and define sleep problems may also be worth considering. Anyway, this was my actual paper that I said I'd talk about today. So we're interested in what factors were actually associated with having a sleep problem in long-term care facilities. And so using that same data set of just under 40,000 assessments, although we see that there is a reduction in sleep difficulties, still over a quarter of the sample were defined as having sleep problems. And so we looked again at those key areas of what we're defining as aging well, so the movement, the socializing, oral health, and general items. And we put those into a model to try and see sort of which items were independently related to sleeping difficulties. And so we see lots of stuff is related to sleep, and I think that's completely what we'd expect, because sleep is so bidirectionally related to lots of things, but not so much. There was some really unexpected findings in that the social connection, the loneliness, and anxiety would seem to be really key predictors for sleep problems, rather than say, over and above things like incontinence and cognitive impairment and so on. It seemed that social connection was really key. And I found in a similar analysis, looking at these same participants when they're at home care, a similar pattern. I'm steaming. I'm not sure what I'm doing for time, but this also resonates. We did some qualitative work as also part of the awesome study, where we went and talked to care partners in residential aged, some care homes down here in Wellington, to try and get a better understanding of what was going on for sleep for residents and how it being supported and so on. And what we found here again is that care partners talked about how their residents have quite desynchronized lives, quite a lot of sleep problems, but they didn't necessarily define them as problematic, as more just a normal part of aging or their dementia and so on. They did talk about things like the routine and the unusual environment as important, but again, those ideas around loneliness, being disconnected from family, friends, fears, and bereavement as a really key area for contributing to residents' sleep disturbances at night. So a lot of their strategies weren't so much around kind of clinical assessments or diagnosis of what a sleep problem, but more person-centered care and supporting those sort of social connections and loneliness, or just comforting through the night. Yeah, so this idea of just having to be there and just listen rather than necessarily diagnose. I think that comes back to my earlier point around how perhaps as we do get older or have more disease, that the sleep becomes kind of part and parcel of that rather than defined independently. Whoops, I've missing a couple of slides off the end. That's okay. What was I going to say at the end? I think overall this shows that sleep's really important. We know that, yeah, a quarter, probably more older adults do have some kind of sleep problems. Although stereotypically we know things like cognitive impairment, incontinence and so on are really important and they do disrupt sleep. I think there's space to further investigate the relationship between things like loneliness and social disconnect, and how, although there's bidirectionality there, that we might be able to support one to support the other. And, we know that loneliness is also a really key area to learn more about. So perhaps, again, treating sleep, better understanding sleep, because quite often, although it may be recognized or thought of as something to do with loneliness, there may also be things like, respiratory based sleep disorders or other primary sleep disorders underlying that are going undiagnosed and we could manage, and so in turn could actually help support that waking life and waking connection and so on. So yeah, is there any questions? Thank you. Kia ora, yeah, John.
It's great to see this work because it's an important variable that we made sure to introduce into the new suite later on. The sleep variable is present in many of the instruments, so mental health instruments have it in it. Also, our new care needs assessment has it in there. So I was interested in what you're doing around caregivers, because we can look at sleep disturbance in the caregiver.
Yeah.
We haven't linked those data to care recipient assessments yet. One of the things I'm working on is to create a composite health measure that basically looks at health problems prior to you seeing IADL impairments, so sleep, fatigue, poor self-rated health, all kind of figure in there nicely. So I think we've got lots of opportunity to build on this stuff for sure. There is a group working on a Canadian paper looking at sleep disturbance in long-term care. One of the things that we're talking about is whether we should make a sleep quality indicator for long-term care. So
it's quite hard to measure, isn't it? Because when we think of sleep, it's not very easy to define using one measure. And when we talk about sleep health, we're talking about duration, we're talking about the time they go to sleep, how many times they wake, how regular their sleep is, and how they.
Well, you're never going to get that in long-term care.
Exactly. So. Yeah. So how do you do it? Yeah.
For one item is not good enough, so you would not have a sleep quality indicator, or would you live with that item?
I think you can. I mean, certainly what we do in things like the New Zealand Health Survey and our other long-term surveys is we'll have one indicator of self-rated sleep quality. So whether you do that from the carer's perspective, whether it is,
But we've got the item on sleep disturbance that you're using in long-term care. We can calculate rates. We can risk adjust it because you've done some work on covariates for it. So then would you, if we saw a variation of, say, sleep disturbance in one home is 10%, in another home 20, and another 30, would you assume that that's a quality problem, or would you just ignore it and that's just noise?
I think the item on sleep disturbance you've got is quite good. It is that kind of standard measure for restless sleep or symptoms of insomnia. You're obviously not capturing everything, but it's certainly better than just asking how many hours somebody sleeps, or the item you've got on fatigue. Fatigue's such a big area, and it's not just related to daytime sleepiness. So yeah, I think when it's a scale that's not just being used for research, it's a really useful item. And it does seem to be about 25-30% when we do larger scale surveys, it comes out around that number as well. Yeah.
So that's the individual level. I think what John's talking about is what if you've got a noisy facility and everybody's bloody awake and have difficulty sleeping? Should you actually intervene at the facility level and have some strategies? Yeah.
Good indicator. If you were comparing, like you say, between different institutes, and one of them had 40% people had sleep disturbance, it might well be then that there's an environmental, or like on a noisy highway, or yeah.
And then if you reported it, the people who had trouble sleeping already would never go to that facility.
It might not, or it might be around something. Some of our care partners talk about, how their strategies. So like reducing things like rounds at night time for checking for continence or medication rounds. That's something they could put in place at their spot. Yeah.
Ulrich.
Ulrich Bergler, University of Otago. Question for you, John. Are you developing some mechanism, some instrument to actually qualify homes? So we have the similar standardized assessment data on care homes, noise, food plans, whatever comes with it.
To describe them in terms of the environmental characteristics?
All of it, whatever is.
Well, our patient reported experience measure, the interRAI self-reported quality of life measure, has a variety of resident ratings on the home environment, including how noisy the place is. So you could get those subjective impressions. We're not really doing stuff on sort of environmental monitoring, though. That's more sort of, there are people who do work with sensors and that, but we haven't done any of those linkages.
So we once a long time ago did an analysis on a rest home trial, residential care trial, and we found that people tended to reflect the background aggregated level of health-related quality of life in their facilities. Happy facility, happy people. It's kind of a circular argument, but you can see how that works, can't you? So you've got to find those happy places. Sue.
More of a comment, Rosie, I think, than anything. It's Sumac now from University of Auckland. And I'm going back about 15, 20 years ago. There was some work done around the timing of meals and the impact that it had on sleep duration. And it found that if the larger evening meal or the larger meal was in the evening, then people slept better.
Yeah.
Now, that worked for a while in some rest homes, and now just about all that I can think of have their main meal midday because of staffing, because of assistance, all those sorts of things. And I just wonder whether that's something you've...
Yeah, I've not measured for it, but it's certainly something that came up in the interviews I conducted, around not just that, but also if people need more than one carer to support them getting in and out of bed. Those people may well be in bed for 12 hours, not necessarily going to bed at their preferred time. And certainly if they've got a lot of daytime sleepiness because they're disturbed sleep at night, then it's contributing because they're perhaps sleeping through meals, or so they're not getting that nutrition or as many liquids at the same time, as well as missing out on the social interactions. So that's where I say it's really bi-directional. And unfortunately, it's good. We have this person-centered care model, letting people have their routines and eat and drink but it also means that some residents, they may well be sleeping through opportunities to connect, not just with other residents, but also visitors at certain times of day, because they're up more at night and they're being supported in their wakefulness at night and comforted, but then they're not necessarily getting... so it's a really hard balance, I think.
I think too it'll be interesting as perhaps we move into aged care. I think just about everybody in the room has their main meal in the evening rather than their big meal in the middle of the day, and so we may see things like that change.
Having to change the way we do things.
I hope so.
Hopefully, maybe. Yeah. All right.
Okay,
Kia ora, thank you.
Okay, thank you very much, Rosie.
Thank you.
Excellent. Now, everybody. Oh, one more question. Yeah, go ahead, Jackie. You have time.
It just struck me, Rosie. So I imagine the home care assessments are more influenced by the care partner, who's more likely to be the spouse, and and whereas the long-term care is more likely to be influenced by the staff in the facility. And I just wondered whether the fact that it's sort of the negative sleep symptoms at home, so the fatigue, the what else did you have? Excessive daytime sleepiness was troubling perhaps to the spouse who was used to a partner who would get up and do stuff. Whereas it looked like in care, it was the need for connection that was more evident, and that the sort of passivity wasn't.
Yeah, it's hard to tell. And I think, again,
Yep.
the way we rate or perceive sleep to be a problem, certainly if you're the 24/7 carer and your sleep's being disrupted, then you're more likely to notice. And it's the same with infants. If you're sharing a bed or a bedroom with your toddler, you're going to hear all of their awakenings and report problem sleep. And so obviously with those paid carers who are working shifts and able to go home to sleep themselves, yes. So I think, again, it's not reliable necessarily to say that sleep problems reduce with moving into care, but maybe the way we report them, or the expectation that sleep is going to be problematic, so the threshold for what constitutes sleep difficulty with these trained carers who've seen a lot of other things. So we definitely need to think of that.
I don't know how you unpick that, but
no, I mean, I think that's why including kind of those qualitative research as well, to kind of get an idea of what they're thinking is going on and what they're doing. And
good point. Thanks.
One care home where I go, there's one lady who has a sign on her door that says, "Do not wake me up until after 8 o'clock." And otherwise, everybody gets woken up at 6:30, 7 o'clock when the staff, so the person-centeredness can only go so far. Well, has to. Okay, thank you very much, Rosie. One more time.